Dear colleagues, the topic of my presentation is brachioradialis rerouting for restoration of active pronation spination. One of the most common methods for restoration of pronation is biceps rerouting, popularized by Zancoli. This is the classical algorithm suggested by Zancoli. The choice of the method depends on the condition of the interosseous membrane and the condition of the distal radial ulnar joint and the triceps function. Although the clinical results of biceps rerouting are good, it cannot be used when the triceps is paralytic or the radial head is resected. For such conditions, we modify the algorithm by adding the brachioradialis rerouting technique for pronation. In 1998, we used the brachioradialis rerouting technique to restore the active forearm pronation in patients with supination deformity due to brachial plexus burst palsy. We published our initial results in 2004. The animation shows the technical aspects of restoration of pronation. Here we see the video. The brachioradialis tendon is detached from its insertion. Tendon is passed through the interosseous membrane from the dorsal aspect to volar aspect and reinserted back into the radius. Thus, it is converted into a pronator. This is our first patient who had obstetrical paralysis and the supination deformity of the right forearm. The pre- and the postoperative fourth-year active pronation results are shown. Here is the postoperative 20th year result of the operated right hand. Another patient who was operated 20 years ago. On the left is before the operation and on the right is after shoulder and before forearm surgery. The postoperative result of the same patient after brachioradialis rerouting pronatorplasty. Here is the same patient 20 years after surgery. You may see the active pronation gain at the left forearm. 14 patients were evaluated and the mean pronation gain was 62 degrees. The supination loss was 11 degrees. Total active motion increased by 53 degrees after the operation. This biomechanical study confirmed the active function of the transfer. The brachioradialis muscle works as a pronator in full forearm supination. However, as the forearm comes closer to the neutral position, the brachioradialis muscle loses this pronator effect. On the other hand, if the brachioradialis rerouting is preferred as a supinator transfer, it will have a greater biomechanical advantage. This technique is preferred very frequently for cerebral palsy patients. It may be utilized also with success in brachial plexus burst palsy patients who may have a rare pronation deformity. In the brachioradialis rerouting spinatorplasty technique, brachioradialis tendon is disinserted, then passed through the interosseous membrane from volar to dorsal aspect, inserted into the radius. Thus, it is converted into a spinator. In our series, we had 48 brachial plexus burst palsy patients. 43 patients had supination deformity, whereas 5 patients had pronation deformity. In the pronation deformity, we performed the brachioradialis spinatorplasty technique. We performed the brachioradialis rerouting technique in our series of 52 cerebral palsy patients. This cerebral palsy patient has a long follow-up period. The preoperative state is shown at the left side and the successful postoperative supination motion is shown at the right side. Here is a supination gain of the same patient 19 years after surgery. In our series, we saw an increase of 83 degrees in active supination and a decrease of 23 degrees in active pronation. Dr. Kima et al. Performed a comparative biomechanical study and he compared the brachioradialis rerouting spinatorplasty, flexor carpi ulnaris transfer, and the pronator teres rerouting. He found that the brachioradialis rerouting spinatorplasty was the second best technique. To summarize our 20 years of experience, we can say that the brachioradialis rerouting techniques can serve as a good alternative in selected patients. Thank you for your attention.